Hi everyone. My name is Dr. R.K. Bhardwaj. I'm a MD physician. I'm working in Rishikesh for the last 30 years. I run my own hospital. So right now we are bombarded with so many newer molecules, and everybody has been very inquisitive that what is the role of the newer molecules, especially the AMPA and LINA. So that means I'm starting here with a question answer, which are the usual question answer session. Mostly people ask these questions. The first one is, how early would you add an FDC, a fixed dose combination, after metformin? Considering that many type 2 diabetes patients have a very high baseline HbA1c. So as we know, most of the patients, they come to us with a HbA1c around 10, 11. And how does the evidence with AMPA and LINA combination help us to choose agents for optimal glycemic control and CV risk reduction, as well as patient with type 2 diabetes? Then another question comes is, what are your thoughts on early intensification with the AMPA and LINA, if they are add-on? And what are the consideration in terms of patient factors you will think while initiating this therapy in the patients? As we all know that metformin is the first line of drug all over the world, and there is no denying the fact. And along with metformin, if the patient is not controlled with optimal dose of metformin, we love to add, the glimepiride. So once the patient is not controlled on metformin and glimepiride, now we have a vast choice. So evidence indicates that early intervention and achievement of glycemic control, that reduces the long-term risk of micro and macro complication in type 2 diabetes. And this UK PDS trial has very clearly shown over 10 years, the patient most likely to have reduced CVD are those patients, cerebral vascular diseases, or old patients which have very tight glycemic control. That means you have to maintain HbA1c around 6 or below 6, preferably. So this also demonstrated a legacy effect on the early intensive therapy, because the difference in CV events rate 10 years post-trial was apparent, even though no difference in HbA1c level between the intensive and conventional therapy. So early use of combination therapy in patients with newly diagnosed type 2 shown to reduce the progression of atherosclerosis compared with conventional therapy. Real-world evidence has also shown legacy effect of early intensive glycemic control. For patient with HbA1c more than 1.5%, above 6, that means we take around 6%. These days we have come down to even 5.7. We say more than 5.6, 5.7, they are pre-diabetic. So let's say the patient comes to you with 7.5 or 8. And that is the time to start patient combination with either SGL2 inhibitor, or you can add the DPP4 inhibitors, especially those cases where you have cerebrovascular disease, patient with chronic kidney disease. These patients, they do need other agents, and to have a tight control and to prevent the micro and the macro complication in the later life. The use of SGL2 or GLP inhibitors or DPP4 inhibitors they can also be added alone or combination with patients without ASCVD, heart failure, or chronic kidney disease if there is need to minimize hypoglycemia. AMPA and LINA combination with complementary mechanism and pleiotropic benefit may be suitable option across a range of patients, including those with established high risk or with the heart failure or chronic heart disease or chronic kidney disease, due to the tolerability of the combination in addition to the potential benefits of AMPA on CV and renal. And we all know how AMPA has taken over the market. And there is no increased risk of heart failure with either of these agents. According to study, early achievement of HbA1c below 7 with AMPA and LINA could reach the target. And we are targeting now not below 7, but trying to be below 6.5. Following advice can be given to patients while initiating this combination: maintain hydration, keep perennial hygiene so as to prevent fungal infection, adequate monitoring of the body weight, that should be your BMI should be within reach, blood pressure, blood glucose on routine basis, that is very important. Most of the people, they come to you after 2 months and they haven't checked their sugar even once. So everybody should have a glucometer and check their sugar on a regular basis, and they should know that What limits are there? Fasting between 70 to 110 and postprandial or random less than 150. So they should also avoid the infections. According to recent ADA 2022 standards of care, first-line therapy depends on the comorbidities. So patient-centered treatment factors and management needs and generally includes metformin and comprehensive lifestyle modification. Treatment goals involves the control of glycemia and CV risk factor and patient-centered approach to care. The choice of pharmacological agents now considers the comorbidities in addition to the risk of hypoglycemia, impact on weight, cost, potential side effects, and patient preference, especially the cost, especially in a country like India. Early glycemic control leads to better outcomes. We all know, including a reduction in long-term macro and microvascular combination, which should be your target. And for patients with inadequate glycemic control on metformin, addition of single pill might be considered to help establish optimal glycemic control while reducing the pill burden and avoiding clinical inertia and intensifying the therapy. When metformin is not suitable and amphoterina is not being considered as an alternative, initial combination therapy may be considered to achieve target more quickly, especially in patients with more than 1.5% higher than the target HbA1c level. It is reported that DPP-4 inhibitors improve beta cell mass, functions via beta cell differentiation, as we all know, and proliferation accompanied by decrease of oxidative stress and inflammatory cytokines. It is also reported that SGLT2 inhibitors improve also the beta cell mass function by the similar mechanism as DPP-4 inhibitors. Although the mechanism of glucose lowering defect is totally different, in experimental study, combination of DPP-4 beneficial effects on beta cell mass and function, especially in the early phase of diabetes rather than the advanced phase. Ampalina is available now as a first-in-class treatment for when SGL2 and DPP-4 combination at 24 weeks. AMPA and Lina, AMPA in the dose of 25, Lina 5 have showed statistical significant HbA1c reduction more than 1. So with the add-on to metformin, which is very, very significant. HbA1c decrements by ampalina has been demonstrated to almost as good as 2%. With a baseline HbA1c, if we have taken in the beginning 8.5% after 24 weeks. Changes in fasting glucose reduction with ampalina was 32.2 at baseline and postprandial was 56.7 at week 24. Higher percent of patients achieving HbA1c less than 7 were reported for a single pill combination, more than 62% versus 32% who were given different either DPP-4 inhibitors or SGL2 inhibitors. Early achievement of goal, only FDC arm of APA and LINA could reach HB target of 12 weeks compared to monotherapies. The combination offers a suitable component in strategy to achieve target HbA1c without hypoglycemia and weight gain. Additionally, it will also reduce the daily pill burden in the population, which is very important psychological factor. And it will also make the patient to adhere to the treatment goal. As we have discussed that in many of the cases, the early treatment has to be given, the target has to be achieved, and it is of utmost importance that we keep the HbA1c level, at least try to bring it below 7%. And now many of the physicians, instead of starting initial treatment with metformin, especially if the patient is coming to you, the patient is coming to you with the chronic kidney disease or disease of the heart, or he's got some other lesion which is to be taken care of. So there you are preferring, even apart from metformin, you are straight away putting the patient on AMPA and LINA combination. So this is a wonderful tool which has come to our hands of the physicians. So I strongly recommend that we start the treatments. As we know, my thoughts on combination or intensification with AMPA and LINA, it's very clear now that we are starting very aggressive treatment early on. And we have seen that starting very, very aggressive treatment early on even has reversed many of the cases to almost pre-diabetic phase. So if you put the patient and watch her closely for 1 year with a combination therapy, including metformin or glimepiride with add-on on SGL2 inhibitors with DPP4 inhibitors. So we are seeing wonderful results. And all these patients where you prevent the micro and macro complications later on, the first target has to be achieve HbA1c as quickly as possible and try to maintain it around 6 or 6.5. So what are the consideration in terms of patient factors? My only consideration comes is that patient, if having other complications while coming to you, like patient is a case of potential renal involvement, or it's an early stage of nephropathy, or it's a case of chronic kidney disease, or the patient has already had MI and is a case of congestive heart failure, or the patient is suffering from other, heart problems, it's very, very pertinent to add AMPA and Glypha right in the beginning, and let us make the most use of this drug. And this is a wonderful boon to our medical fraternity. Thank you so much.